Growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner here, and you are listening to The Lionhearted Dentist. Welcome. I hope everybody had a pretty good week. Last podcast, I got totally sidetracked. I meant to talk about giving you specific examples of how the protocols I try to share with you lead or can lead to these multiple monster weeks I've had for many, many years, including since the pandemic. And I want you to know how these podcasts are developed. I'm literally taking notes now during a week, just like I have when I've written other books and things, to how something translates that I can share with you. Because the truth is, I can't remember if I just don't do that. So I hope it's resonating with you. If it isn't, you'll hurt my feelings, but I need to know. So you can write to me. There's a million things I can talk about. And as you know, last week, I ended up speaking about the importance of other parameters that lead to a great organization, and that was the monthly meeting, and we had a little bit of talk about the daily meeting. And trust me, when I started that podcast, that wasn't even in my brain. And that happens, and you know by now, if you've been listening to me, that I said early on in these podcasts that this would be like getting together with somebody that hopefully you trust and respect, and having a beer or a cup of coffee with them after work or on the weekend, and we're talking shop, because that's what you need. I wish I had had that early in my career. And so sometimes that dialogue goes off in a different direction like it did last week. But I want to get back to what I had been doing for several weeks, and that was trying to tie in how the things I'm getting you to do, when I talk about that, the clinical skills that I think will pay off the most for you. Now, if you don't like the clinical skills I've emulated in my career, or that I've assimilated, then I'm sure you could do it with other parameters, except for the oral sedation one. In other words, I'm a heavy advocate of you learning surgical skills. Atraumatic extractions, which, by the way, you can learn right in my office in New Jersey if you're from the United States, without a license in New Jersey. I have that all set up. It's an amazing, amazing agreement that I have with the state board. And we also do that for implants as well, but implants require a certain amount of training that I have to approve, didactic training that you've had. So what I'm saying is that if for some reason I couldn't do surgery anymore, I am positive you could structure the Lionhearted dentist type of office to supplement that with ortho, endo, a lot of services that I don't provide in my office. There's no doubt about that you can do this with other services. But for me, I've been advocating for most of you those surgical skills, because it goes so in hand with the sedation patient. So let me get back to trying to tie in cases that happened with me in recent weeks. And the result was just tremendously satisfying weeks, which is what I'm hoping for you. So as I say on every podcast, please feel free to write to me. I want you to write to me. I enjoy it. Sometimes I get bombarded, and sometimes I get very few. When I get bombarded, it is okay to remind me if you haven't heard from me in about 3 or 4 days, because sometimes I drop the ball. Anyway, we've been having some pretty darn good monster weeks, and I've taken some notes to tie it all together for you. So one that comes to mind, we'll call patient Terry, a few weeks ago. And I'm really giving you one specific day that was a $36,000 day of collections in my office. And again, I'm only saying that to you because, that blows my mind too. When I hear me say that, I can have these weird weeks where I do, 20 on a Monday, horrible day on a Tuesday, nothing. And then somehow, some way, they all end up, most of them. I don't have a percentage for you, but it's most of the time pretty impressive. And they happen so much like the one day I'm giving you, which was a Thursday of a few weeks ago. That week ended up collections of 88,000 collections, not production, collections. And when I look of what the case presentation outcomes were or what I was presenting, it's all tied into what I'm trying to get you to do. And one of them was a patient that was 71 years old, had come to me a few weeks earlier. We'll call him Terry. And he had Parkinson's. Now I want you to picture this. So he had gone through all the protocols that I've shared with you on multiple occasions. I'm talking, his wife must have called for the new patient visit. She spoke to a dedicated new patient coordinator. It's done it forever for me, and went through that protocol, had the appointment made. So all these things were adding to what the outcome was going to be this day in my office. Came into the office, and when I walked in the room, he had pretty advanced Parkinson's. His wife was in the guest visiting chair. And by the way, for years I just used a dental assistant chair. I don't know how important this is to you at this moment, but if you really adopt this policy of having the significant other come with the patient on as many occasions as you can, a few years ago I broke down and I bought these really nice rolly chairs. They weren't inexpensive, they were several $100s, but they're compact, they're very comfortable, and I feel a lot better. I always worried about a patient falling off the dental assisting chair. Never happened, but it was always an uncomfortable feeling for me while I'm talking to the patient in the operatory chair. Anyway, she's sitting there, and he is, as I'm speaking, going through significant movement. This wasn't a little tremor of his hand. This guy was moving a lot. He spoke okay. He didn't communicate that well. And the chief complaint of that given day was another tooth had broken. In this particular case, it was a central incisor. He only had 3 remaining maxillary teeth, and he had about 8 mandibular teeth. Now, he did not have bone loss. He had a history of crown and bridge on these teeth. So, when I tell you I'm doing a case presentation, all of these thoughts are coming in and out of my brain as I'm sitting there viewing, talking, picking up information with this patient. Like, I'm thinking to myself, well, how did that happen? Of course, that would raise the question of how long has he had this level of Parkinson's. I started speaking to his wife and him. So you got to understand, I am looking at both of them. I'm not disrespecting the patient. It was clear in this particular clinical example I'm giving you that the spouse was a significant player in this. And I was able to examine him. We got very limited radiographs. We couldn't take a CT scan because we couldn't keep him still enough. But somehow, and you got to remember, this is part of this. If this was not a patient that was capable of exhibiting cooperative behavior, or if mentally he wasn't cooperative, it would have been a very short visit. I'm not advocating that you guys try to be a hero and at the same time traumatize a patient more by trying to be that hero. I felt by looking at him, I wasn't sure. I wasn't sure if I could treat him. So I looked at his mouth, and I did have enough x-rays and enough information to be able to come up with a treatment plan. So here was my treatment plan. We didn't have periodontal issues. We had missing teeth issues, and we had certainly dexterity issues on his end. I mean, this is a patient that was moving considerably during the whole time I'm sitting there or standing, looking in his mouth or talking. I've had worse in my career. I have. So I have a little experience with this. And so I went on to say to both of them that my suggestion would be the following. And I recommended removal of the hopeless teeth, which was only 3, 1 on the maxilla and 2 on the mandible, under sedation. And if I am successful, my treatment plan would be, believe it or not, a bridge in the anterior portion of his mouth, a partial denture around the 3 remaining maxillary teeth, and a partial denture possibly on the mandible. Now hear me out on this, because these are those moments of truth that I'm not sure where you're at, what you would come up with. I mean, certainly one of the thoughts in my head was a full upper denture. That was one of my thoughts. And I shared that thought with the patient and his wife. But what I said is this. I said that he's got 3 decent teeth left, which is a compromise for a partial denture. It is. I understand that. But if he was my relative, I would absolutely give that a shot. Because I know this patient who, again, I'm not even certain what he can do with his hands or not his hands, would be able to masticate and function better with a partial that held on to 3 teeth. Remember, there's no periodontal compromises on, it's only 3 teeth, but there was no compromise of those teeth. They were in excellent condition. You know, if they weren't, obviously we'd be talking about a denture. And I'm not sure how we would function with that. Nor can we talk about a sophisticated partial. And on the mandible, my inclination was if I can give him 8 teeth in the front that are fixed, and we don't even have to worry about wearing something that we have to take in and out, then we win. And you got to know that when I'm advocating you in this moment to talk like this, I am a big visual model guy. I've said this. And so I am not just saying a partial denture. And I am talking specifically about the kind. And when I have 3 teeth, I use, I don't know what you guys call them in your states or countries, a flexible partial. It's not my go-to. It's my go-to if I only have 3 teeth. And my experience has been some people do very well with them and some people not so well. You know, so remember, this is a patient that's got 2 cuspids, 1 central at this point, because he's going to lose the other central. And I was very, very clear with both of them that I'm not sure how successful I'll be with my sedation protocol. So there you go. There's no way that you're treating this guy successfully with nitrous oxide only. It's not happening. It has to be an enteral sedation type of protocol for this guy, which is so rewarding to you. And I also, I got to tell you, I stipulated that if he couldn't function well enough with a lower fixed bridge of 8 teeth and the upper partial denture on 3 teeth, and we think he could handle it based on his experience at that point with the upper partial, then we would proceed with a treatment plan of a lower partial. I was not counting on it in the beginning of the initial recommendations. I was fine without it. So the patient presented himself on the Thursday that I'm talking to you about, and it was a blessing, I'm telling you. The protocol that you hear me talk about, the oral sedation that so many of you requested and I've given you, it's a right to me if you haven't, worked stunningly well. The patient, you couldn't tell that he had Parkinson's. His vital signs were beautiful. Of course, by the way, I'm not a snake oil salesman. I want to protect you. I want to protect my patients. So when there's ever a medical condition like this, I'm getting a clearance. If you want the clearance I use, it's way more than what most of you may be used to. I adopted it, to be quite honest with you, when I had an in-office course with the Mish Institute a couple years ago. We're always trying to up our game. And that was 2 years ago, and I upped my game on getting a a okay from the primary care physician. And if you want that, if some of you haven't requested that, write to Beth or myself and we'll get that to you. It's very well done. It's very clear. I actually modified theirs to make it even clearer. There's no way that the physician doesn't know what I'm using. It's very clear language, what anesthetic I'm going to use, what my sedation protocol is, and that's what I really wanted to know with this patient. I questioned his wife on what drugs he was on and how effective, how long are they effective, which is relevant here. So I got to tell you, it was a very, very rewarding and gratifying short treatment. I only scheduled him for an hour because I wasn't sure that my protocol would work on him, and it did. You know, that turned out to be a fairly significant treatment plan on a patient that hasn't gotten treatment for many, many years because nobody knows what to do with him. Either he's an IV sedation patient in many other offices, which they chose not to do, or he lives life like he did. And I got to tell you, it was heartwarming to see and motivating to me to encourage you to get your sedation license, to see the results of that. So that was one case. I want to give you a converse case, the antithesis of this, that I agreed to and I made a mistake several months ago. This was a 25-year-old whose history was that he had never been able to been treated without IV sedation, and they didn't want to do that anymore. Okay, and I walk in the room. You got to remember, I've had extraordinary, successful experiences over 25 years of doing this. And so there's a side of me that thinks I can almost be successful on anyone. And that's what I thought with this young man. And the reason I'm telling you about it is because he was in my office that day as well. And I have had success with him. But success is not always getting the job done. Success is always, what were the visits like for you? What were they like for your team, for your staff? Did you just get slaughtered to get through it? And yes, you got your work done, but man, it just wrecked you for 3 days. That's what this kid is. Because he's not compliant. For some reason, he fights everything we do. And I'm telling you this because when you get a patient, especially one that has never had anything but IV sedation, even if they're 25 years old, I would hesitate to tell you to proceed with that patient. This case was significant, by the way, the case of this young man. It included multiple root canals, which I sent out. They were molars. I wouldn't have dreamed of trying to do that on him. He's combative. He is almost violent, but certainly verbally disrespectful when he's on this medication, which I've seen so little that I don't even really bring it up to you when I recommend a protocol, because I don't even know if it's statistically measurable or what it really is. But some occasional patients act like bad drunks, like people who are nasty on alcohol. And this kid is one of them. And yes, I got through preparing and seating on this day 6 crowns that were beautiful. And I had to deal with, and my team had to deal with, 100 F-bombs out of his mouth while we're working. That's not successful. And this, by the way, is about our 4th visit with him. His mother and his parents are delightful. By the way, this is what you can attract when the word gets out that you have an enteral sedation practice. And I'm telling you, most guys, most of your colleagues aren't on board with that. They'll give nitrous oxide. They'll give a Valium. And that is simply not as effective as the protocol that I've used for many, many years. But sometimes you bite off more than you can chew, even if you're successful. And this is a big money case, by the way. I could give a hoot. And I'm not even done, by the way. I have about 3 visits left, and I'm kind of stuck in it now. You know, because I am a human being, and I'm doing it more for the mother and the parents than I am for the patient. That's really how I feel. I had a consultation with him off the drugs in between maybe the third visit and the visit I just described. And he was pleasant. And I brought up the fact that the drugs could be the cause of it. And we altered the dosage, and he swore to me that he'd be cooperative. And as soon as he sat down, he was not. So this was on that day too, by the way, on the monster day of the monster week. Then I had, and I'm doing this on purpose because I'm trying to show you how these weeks come about. Where do they come from? A lot of you have written me before and say, how could you possibly do those numbers? Well, because of the skill set that I've been fortunate to acquire over the years by being such an advocate of CE continuums. You know, it's not going to come to you by YouTube. It's not going to come to you by a weekend course. You have to be willing to invest time and money in certain arenas to become good at them enough that you feel very, very competent to do a wide array of cases. And when your base cornerstone is oral sedation, trust me, no matter where you're located, no matter what country that you're in, you are going to attract cases that can generate significant productivity and usually satisfaction, not the case I just described. But, you know, in that given day, I had a gift come in. What's a gift? Patient comes in. This is the opposite of what I just told you. Of both cases, the case with the Parkinson's or the combative 25-year-old. You get these cases because this patient knew patients that I had done. And he was 50-some years old, a terminal lower dentition, wore an upper denture, had adequate generous bone, and he wanted his options. And again, I want you to feel this. When I'm in there, of course, in my mind, I'm salivating over the fact, because he said when the patient mentions that they may want implants, at least I believe they've done some research and I'm in the ballpark with them. I don't have to explain as much what an implant even is. And so, again, I don't push them though. I always give them all the options, and the options they put in their hand and they visually touch and see. And that means a lower denture. That means an implant retained denture on Zest locators. And that means an implant retained denture model on a bar. I have all of those. And I advocate that you get those if you're delivering those kind of services. You know, I don't know, it's been a lot of years, maybe it's been 15 years, but it's happened to me. Delivered the prostheses on the day of insert after maybe 4 months to 5 months of treatment. And the patient said, this comes in and out of my mouth? I mean, they've been wearing a removable for the last 4 or 5 months. Are you kidding me? So I'm probably not the only clinician that's ever happened to. So yes, you better believe, not only am I showing the models, you know how I tell you that I always want you to evolve? I've been in it 40 years. Let me tell you a new thing that evolved about 6 months ago. And I don't like doing it, but I like it when it's in the chart. And maybe you're already doing this, but I literally type up my notes on every new treatment plan that night, that day of it. Now you may say, well, of course you do that. No, I used to do it by hand, or sometimes I would take my charts home and do it over the weekend. And I just remember every nuance. I even have a very expensive tape recorder that is non-threatening, and I've never used it, by the way. I bought it so I could tape multiple stories like I'm giving you recently, and so that you could hear the patient and me dialogue, and I would make a product out of it that you could buy and listen to on multiple stories about these different case presentations. Right now, I'm obviously just describing them to you. I don't think it's a bad idea that you tape these, just like phone calls are taped for quality assurance when you make phone calls. Because, you know, sometimes people have selective amnesia. So anyway, this was a gift because this case went right through, and it's 4 implants on a removable prostheses on a bar retained implant by 4 implants. That is the perfect case for me. Abundant bone. I mean, it was an absolute gift. On that same day, and I hope you're understanding why I'm telling you all this, I delivered 10 units of crown and bridge, just regular crown and bridge, no implants, on a different patient that was flawless. I mean, will it be published in the next aesthetic dental magazine? Probably not, but I used a very high-end lab. I did preparations and materials from all the mentors. You hear me advocate for you. And it was very gratifying because it went just as planned. And trust me, in your career, you will have some that don't go just as planned. This one did, and the patient was very, very obviously pleased. And his wife, who was in the reception room, remember, this patient was prepped, teeth were extracted, there was crown and bridge in this case, and he did have implants that we have not restored yet on the posterior left of his dentition, maxilla. And his wife, who was waited patiently throughout the multiple visits, was so pleased. She made a new patient appointment. So everything on certain times, oftentimes, seems to work together to reaffirm the belief that I have that these protocols that you hear me espouse are so worth it. And you know, on a day like that, I had an old timer come in. This guy had to be 80. This guy's suffering from pancreatic cancer. No big deal. He had pancreatic cancer is a big deal. When I have patients like that, believe me, I hope when they're in hygiene, there's not something I diagnose that I have to see them for. But he had significant caries on the buccal of a molar, and I was scared it would cause him pain. And he was in on the stay that I'm describing for you. And we did the restoration. It didn't take very long. It was only a buccal, but it was deep. No carious exposure, no pulp exposure. And I went to the front desk because we walk every patient out. I don't, the dental assistants do. And before they walked him out, I told them, tell him when he gets to the desk, that one's on me. Now, it didn't take me but 30 minutes to do that, but it felt really good. And he walked around the corner, saw where I was in my private office. Again, it was just a filling. It's not that big of a deal, but it's part of what you're able to do when the symphony is playing perfectly, if you get what I mean. And that was part of that day. On that same day, I had another patient who I simply had done a 3-unit bridge for, and he was coming in for 2 final operative fillings. Yes, we do fillings in my office. I do fillings. Don't like it. Try to delegate that out to other members of my team, but on occasion I have to do them. And this particular patient, out of nowhere, said, could I ask you an important question? And the question was, would I be willing to see a very unfortunate friend of him who's homeless? And my answer was clearly, yeah, I'll see him. I'm not sure what I can do. I'll need to get information about his health, which I'm not sure it'll be as easily attainable as it could be normally if he wasn't homeless. But these are all parts of, when I say monster day, it's not just we had a good collection day. It's the execution of procedures, sometimes most of the time at a very satisfying level, and reinforcing that we are doing things right. And I do have days, I haven't had any in a while, thank God, where for some reason it doesn't go that way. And I need to make that clear, but that doesn't happen that often. And thank God it doesn't. And I'll give you one final case, and that'll be it for this particular podcast that I'm trying to put together for you. And this one's important. This last patient was a new patient on this day that drove 2 states to get to our office. So I would say, without exaggerating, he drove 3 hours to come for a consultation. I do advertising on the radio, and somehow the radio from our state reaches his particular state. My radio ad is me talking kind of like I talk to you. I change it about every 3 to 4 months. I have a tremendous deal, and I want to tell you about it real quick before I tell you about the patient. Because you might be thinking, well, God, he's on the radio. And how do you do that? And it really depends. This radio station is very affordable for me. I'm on 5 days a week, 5 times a day, 10 minutes before the hour. So I'm on at 10 of 7 in the morning till we do it 7, 10 of 8, 10 of 9, 10 of 10, and we're on 2 times around dinner time. And it costs me about $800 a month, and I sponsor the weather, and I'm on for 1 minute. And my conversation, it's my voice. It's just, hey, it's Dr. Steve Rasner, your dentist. And I said, today I want to talk to you about blah, blah, blah. I've offered that ad to you as one example of many ads I've done. And some of you have taken me up on it. And I can email you literally the audio of that ad or any ad I have. So if you want that, you need to write to us. And, don't do this if you're located in, Chicago, Philadelphia, Los Angeles, because the price will be formidable. It won't be worth it. I don't know if you've noticed this, but certain ads attract certain kind of people for me. And by the way, this is an oldies station. It's an oldies station. So it attracts, I would have to be honest with you, people generally 60 and up, which is the wheelhouse of my practice. Absolutely the wheelhouse. And probably yours, if you think about it. And, we talk about trust, confidence, feeling safe, not having somebody hard sell you. You'll see if you ask for a couple of the ads. So this guy drives, and he comes in, and when I walk in, flashing forward for you, his wife's sitting in a chair, he's sitting in the clinical chair, and I'm getting impressions by looking at him and listening to him. And immediately, I got a blue collar, kind of hard around the edges guy. Not nasty at all. Just, I want, what's his chief complaint? His chief complaint was 2 broken teeth and probably some cavities, is what he said. I said, well, why are you here? I'm thrilled you came to me. So this is the kind of conversation that's going on. I walk in first, and again, this is in prior podcast. You've heard me talk about it. First thing I walk in and say, often I'll say, I'm Doc. Nice to meet you. How did you guys find us? So he told us about the radio. I said, wow, that's really a long way. And I have a lot of patients that actually come from other states that fly in. But I didn't say that to him. I said, wow, I got to tell you, I'm really honored that you drove so far for my services. And I'm really appreciative of it too. That's how I started the conversation. Looking him dead in the eye and being sincere. When I explained my philosophy of care, comprehensive dentistry, which he heard all that, or he wouldn't be in my chair at this point. He knew all that from my new patient coordinator. No surprises to the patient. He knows he's getting a complete set of x-rays. He knows I'm doing a full exam. And long story short is that this patient, and I didn't want him to need a lot. I really didn't. I never do. And I'll say that to them if I think it's appropriate. And I went through my 5 arenas, and he did need quad scalings, absolutely. But he had good enough bone left. He was 60 years old. He needed quad scaling. He was going to lose 2 teeth, and we were going to not replace those teeth. They were posterior molars. I don't remember offhand which exactly, but he also needed 5 crowns. Absolutely needed them. And 1 or 2 of them were redos of prior crowns. And this guy had patient had multiple crowns prior to me, and he had multiple root canals. So my general approach to him was, tell me what you're looking for. That was early in it. I know you have a couple broken teeth. I know you know that. What's your goal? And he said, I'm tired of going every 6 months or every year and getting, I need more work. I need more work. Okay, I said, so here's what I'm going to do. I'm going to look at you really carefully. And I want you to know that I'm going to tell you the way it is. I'm going to tell you what I believe by looking at the 5 areas I'm going to look at. And I told him what those areas were and why I was going to look at them. And then I told him, you're going to understand completely why I'm going to recommend what I'm going to recommend. And then it's going to be up to you what you want to do. I can assure you by looking into your mouth that you'll probably need to invest more out-of-pocket money than you probably ever have. And that's not because I want you to. It's because I can't control that part of the equation. I can only have you either believe me or not. And let me tell you something. As I went through this type of talk with this patient, even though he was pretty, as I said, rough around the edges, tattooed, real muscular guy, and that doesn't make him rough, but I'm trying to give you the image. Talked like a sailor. He didn't cuss or anything, but just that kind of image. And before I even got to tell him the fees and everything, which they often say, he said, look, I like your approach. You tell it the way it is. And whatever you tell me, I'm going to do. Because he hadn't had a lot of sophisticated work, so I was trying in my mind to see, is there anything I can stage for him? If by staging his work, meaning doing some of it now and some of it a year from now, would I be doing him more harm? Would he lose some of the teeth I was not going to treat? Would he need root canals on those teeth? And this was all communicated to him the way I'm talking to you right now. And before I finished, he says, I want you to do whatever you think you need to do. Bro. That's what he said. Bro, not doc. I got to be honest with you, I liked it. I did. And there's a guy that I would say happens often in my practice that has not had, I told you he had a couple crowns, but they were isolated crowns. And one of the analogies I used for him was, and maybe you guys won't like this, but I thought it worked for this patient. I said, if you were leasing your car, and your mouth right now is that car, and now you want to know whether it's worth investing in that car before you buy it. In a way, that's what we're doing. Should you invest in your mouth? Will you continue to have multiple problems every time you come to see me? I said, not if you listen to me. Not if you allow me to do what I need to do in the beginning. I can't control what happened before today. And not if you're willing to come into the dentist every 4 months, period, which you're going to have to do. If you don't want new work every time you come in, then you're going to have to allow me to see you in more frequent intervals so I can prevent that. And I want to prevent that. Again, I don't know if this is coming across, guys. That product that I told you that I want to create would be maybe 50 stories like I'm giving you, but you'll hear the patient and me talk. So if you think that's a good idea, give me some feedback. You also heard me say a couple podcasts ago that I'm seriously considering, once the pandemic dies down and it's okay to travel, of giving you a 6-month notice of having a 2-day live, let's put this all in action, man. Let's put this all together. And if I have enough of you that seem interested, I will put that in motion. And that's an invitation to my friends in Europe and anywhere else. I would make it worth your while, and it would be a really great, perhaps changing 2 days of all of our lives. Thanks for tuning in. I hope this helped. I know this one was kind of long. Write to me, Dr. Rasner at AOL.com, for anything that you want. And have a great week, and I'll see you next week on The Lionhearted Dentist.